Okay, we're gonna go ahead and call to order this board meeting for the Seneca Healthcare District Board. All here, we have Sherry is here, Ken is here, Shelley is here, I am here. Do we have Rich online yet? Looks like not yet. Okay. If you could let me know when he is here, that'd be great. Thank you. All right, let's go ahead and do the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Brings us to item number 2, additions or modifications and deletions from the agenda. I have none. Anyone else, board members, staff? Thank you. Then I will move on to number 3 and accept the motion to approve the agenda.
Move approval.
Thank you, Sherry. Do you have a second? Second. Thank you, Shelley. All in favor? Ken?
Right.
Sherry?
Aye.
Shelley?
Aye.
That brings us into our public comment period. See, we have none of the public. Do you want to say anything today? Not really. Thank you for coming. We didn't have any questions or comments submitted in advance. Anyone online have anything? All right, hearing none, let's move on to item number 5, approval of the September 5th, 2020 regular board meeting minutes. Board members have a chance to review. Any comments? Motion to approve? Thank you, Ken.
Second.
Thank you. All in favor, vote.
Aye.
Jerry?
Aye.
Ken?
Aye.
And I'll vote aye. And that moves us right along to our staff reports.
Great, thank you. Good afternoon, board. So just one quick updates on the construction. I know Donna will fill in some of the gaps, but I can tell you that I'm very, very pleased with what's happening thus far on the property. They are moving right along and keeping things moving. It looks as though they're going to try to push through to early December and then prior to the shutdown, winter shutdown, to get all the infrastructure in place. And my understanding is the light posts and fire hydrants and grading the road and things to that effect. Then they have 120 days that they have. We're looking at an early April 1st, actually, full stay, beginning the construction again, depending upon our winter, but we do have mitigations plans that are going in place if we have a heavier snow, about how we can clear the pad and move for our April start. So we are looking at how we can actually get ahead of winter, providing she doesn't melt in time. The things don't melt in time. Next year is going to be very, very busy. We can talk to about more, but we'll have steel going up. We'll have, by this time next year, we should have a fully skinned out building. It looks just like a hospital on the outside, with the ability to do our internal TI work through the winter months for the following year. So the team is really good. Just everyone is just really, really committed to getting this done and really doing it on a good timeline. So really no big hiccups, and we'll let Donna fill you in more, but during her thing, but I'm pleased with that. So winter has come. We believe winter has come in our winter activities, and there'll be more filling in from others through their reporting. But I can tell you that there's going to be a continued major focus on our revenue cycle. That is everything from what is built in the system to our workflow. We've been working through some things, especially in the emergency room, the workflow for the point of care, for the care providers to be able to capture what they're doing accurately in Cerner and making sure it's transitioning into a bill and revenue. We are making headway. We're starting to see some indicators that we're capturing more and more at the front end. Steve and his team is working really hard to ensure that whatever they touch on the front matches to something in the back, something that moves through the process, the billing process quickly without a lot of hiccups. So that will be a major continued effort of ours all winter long in preparation for our spring and summer. We really want to fine tune Cerner this year and get it right. That's a big one. So fine tune the workflows. Outreach to patients for preventative. So winter is also going to be having us, since we are now well established with partnership as the medical payer, we are really going to do an outreach to the communities of Pinetown and Westwood in a big way, starting probably next week? Yeah, next week, as early as next week, working with them not only to address the assigned lives, but to to talk to them about coming to us when they're not assigned to us. You know, we're closer, there's availability, we can absorb some things. We're really gonna be working on baseline, our partnership is really big on preventative care. So things like your lab work or your EKGs or your colonoscopies, things that haven't been done in a period of time, we're actually doing outreach to get people to come in and baseline all that. So that we can get ahead of that from a population health perspective. And that should reflect in a rise in our volumes, procedural volume, in the clinic during our slow months, which is what we really want to do. So that's gonna be a big push.
Where does Greenville fall in that whole?
Greenville is
mix?
annexed by PDH. They can go wherever they want.
Well, that was my
Right.
question.
And a lot of them do come here. A lot of our staff live in Indian Valley. So, but they're not held to go to the specific area of the service, who owns the service, which is PDH under annexation, but they can come here. We haven't really talked too much about marketing to Greenville,
Mhm.
but I think that should be something we should pay attention to as well, especially as it starts to develop more and more.
I was just looking at that map actually,
Yeah,
and
thank
Canyon
you.
Dam is even outside of our technical boundary, which I was kind of surprised by.
Well, I mean, it just occurs to me that I'd prefer to drive here than I would
Yeah.
to Quincy.
It's in there.
Especially with, if the road work is going on,
Yeah.
Right.
that's been going on.
Right. I think that we need to do maximum effort for our full-time residents in all of our service areas, but you know, in the summertime, certainly, we've got ideas on how we're going to really market out to our visitors. You know, we've got to do a better job of that. I agree with the board when you say, hey, you know, we've got to be recognizable, we've got to be out there. We're gonna do a much better job this summer and we're starting to pay attention to those things and really get a plan in place for that.
Can partnership provide us with some numbers of how many potential patients that could be for us?
They can give us the numbers of those people to cover, and we just compare and contrast it against those that are assigned, so we can get an idea of the delta. It's actually in Westwood quite large, you know, that we could potentially get assigned over here. Go ahead, great.
560, yeah, 560 lives or something.
In Westwood?
Westwood, yeah.
Wow.
So we
And
have,
we're assigned how many? Was it 150, Steve, or something like that we got? So there's a considerable number of them that are assigned back to Banner.
and then every month we get a list of the new lives and then we have to reach out to them, you know, so it's a perpetual type thing that occurs.
Well, and I can say that the Northeastern has a provider now in the clinic in Westwood. I don't know how long that will stay, but there is a provider there. In fact, we're losing one of our LBNs. She lives out there and would like to, she'll be going over there. So we want to really check the status of that. This is Rich. Can I take 1 second? Yes, sir. No, there isn't. Why don't you go ahead and try to dial back in, Rich, and we're looking for you.
Shall I send him I just resent him the link.
Okay, she just resent you the link, Rich. Try that one, okay? All right, sorry,
Yeah, and with
he's trying to get on.
We talked about too, about there being different processes for how they can switch over to be
Correct.
on with us as well.
Yeah, we can't steer them.
Yeah.
There's a
No.
little,
Mhm.
but we can certainly poke.
Yeah, if they choose, like some patients, when they did not have a provider, they were seeking care here. And from Steve's perspective and revenue cycle,
In our system.
they're in our system, they're denied bills, and so we have to call them to see if they want to make us their home base. And so there's two ways to do it. We have the paperwork that they can fill out and fax for them, or they can go on their portal and change it on there. Some patients don't even realize who they were assigned to because it was just by location, okay, you're here and have no idea. And so, we'll be doing phone calls to them that are seeking care already and making sure they understand, the process. Now, what happens is if they seek the care here and they don't switch their base, like they come into the walk-in, okay, we can see them. But if we try to do a referral, we cannot. It's the base hospital, so we would have to refer them back to that and stuff like that.
We're experiencing that now with
Yeah.
some 200 referrals, so.
When we had also talked about trying to capture that at the point in which they come in, that
Exactly.
way, he never has to deal with the denial at the backside.
Exactly.
So maybe having a station or having the auxiliary set up to help them change it if that's what they wanna do.
Okay, good. No, so there's an all-out effort to really capture that market. I think it's just
That's a great plan.
we've got plenty of capacity, so that's pretty good. Some other things, solidification of staff, we'll be talking about moving away from registry, moving away from registry, moving away from registry. We are getting there. It's kind of a 4 steps forward, 3 steps back. Sometimes depending upon everything. The one thing that we are really pushing on is getting rid of registered positions in our ER. So we've had a number of new ER positions, very qualified, come to us. This is really important because our inpatient volume, we're really gonna focus on trying to get our acute and inpatient volume up. That requires physicians that will admit and follow. And when they're registry, they just wanna do their job and get out, right? If we have more permanent physicians, they have more buy-in, they work more collaboratively with the other doctors from a hospitalist perspective. So that's another big push for us, is to really drive our admissions and inpatient volume, but we need a really stable physician staff in the ER, and we're getting there. We've got some really good things. January schedule's looking good, and February's gonna be amazing, so. Once again, a winter project to get ready for our summer movement. Couple things just that are also winter, preparing the final bid documents for the maintenance shop. Out here, we've got our, looks like final bid docs going out, and Linda and I will be releasing that just to get an idea of the costs. This is not a critical path item, we just want to get it out there. I'm gonna probably float the bids also for the second floor. I'd like to get an understanding of the cost of that. I really don't know. We have final docs on that as well. So it's just a matter of preparing everything for an understanding by this board of what it would cost to move chess pieces in the great strategic plan of the campus. And the other one, and I think Brady's gonna hit on this a lot more, is that there is a big movement right now to develop in joint venture under JPA with all 4 other hospitals, our own mobile MR. Every one of us has been canceled by our provider. So,
And Banners was down not that long ago,
what's that?
and Banners was down not that long ago.
Banners was down, so they canceled PDH, EPHC, they canceled MODOC, they canceled us. With 30 days, I think it's 30 days notice. And mayors had never had it and they want to establish it. So there's gonna be a lot more dialogue. There will be a capital investment in this. I have a pro forma that will be producing with Steve's assistance in some of the numbers. Once we have a better rounded out number for the whole project.
Do we think there's any grant opportunities for this?
I don't know. It's something we will look into, obviously, but there's a formation, there's the Joint Powers Authority or the JV that we've got to put together, some governance around how it's run and things. So there's some work to do, keeping in mind that building an MRI in your own coach takes anywhere from 6 to 12 months. I will be going to the RSNA. I'm sort of helping lead this because of my background. I will be going to Chicago where the coach vendors are there. You may see in November, my request for a future capital consideration.
And you're talking about the machinery itself, right?
The machinery and the coach,
And the coach, okay.
the coach, the trailer.
And so the
It'll be
JPA is
hours.
just going to articulate the schedule, how it operates and. Okay.
Who pays what, how do we pay?
Right.
It's ours, and it will run the route just with the 5 hospitals. And that's all its route, and it won't be assigned anywhere else.
Not all 5 are on Cerner, right?
Yes, they are.
They're all, okay,
Everyone is on Cerner,
that's good.
and everyone uses the same tax.
Right, I was gonna say, they only use that.
And we always use the same radiology system, so it's actually a really good opportunity to take a look at really how we joint venture as a community, a consortium of hospitals, to our benefit. You know, and I did just a quick pro forma, and I think the ROI was a year and 3 months
Oh, not bad.
on a 1.5 million dollar investment. $1.6 million investment, so. Okay, that's all I have. I'm glad to take questions on any of this. Lots going on.
questions, board members?
No.
Exciting times,
Yeah.
very exciting.
Good stuff happening, yep.
I think Judy.
So I didn't get for it to, but it's now. So we get very busy with up and down. So today is the last day for people, our employees, to get their flu vaccination or to sign their declination form. So if you're a patient forward employee, if you don't have your pink sticker on here, then you must have a declination on file, and then you'll be required to wear a surgical mask until April 30th, which is typically when flu season is deemed over by the public health officer. We did have our drive-through flu clinic. It turned out not to be a drive-through because we had marginal weather and it was freezing outside, so we went to the Memorial Clinic. But I think we had actually more nurses and volunteers there than we had actual recipients. We are going to be doing flu shots for the Collins Pines employees, so they specifically asked us to do that, so we're going to accommodate them.
Are we gonna help with the schools or is the county then?
I think the county has the schools taken care of. They didn't ask for our assistance with that, so. Let's see. Emergency department or EMS updates. Last time I told you about the IV solution shortage because of the Baxter area getting hit in North Carolina by the first hurricane that came through. Baxter is now given an extension on the expiration dates of fluids that currently are not expired. We can add an additional 6 months to the posted expiration on each one. So we have that throughout the facility. Education's been done, so hopefully that'll get us through this until their operational death. If you haven't heard, sure you have, that the Peninsula Fire District and Chester Fire are in their annexation process. And there will be 2 public hearings next week, one on Wednesday at CPUD in the evening and the following Friday at Peninsula Fire District about 11 a.m. if you want to attend.
What was the date again?
What's that?
What was the date again?
11, so the 6th is at CPUD at 5:30 and the 8th is at Peninsula Fire at 11 a.m. I know I'm planning to go to the Peninsula Fire one, and I did watch CPUD's board meeting this week where they did discuss it a little bit as well. And from what I understand, it sounds like many, if not all, of the EMS assets will be possibly acquired through the annexation process.
The annexation process, my understanding is without a lot of details, gone very, very well. There's been good
very
working
positive.
meetings.
And even their report, I felt like at CPUD this week was fairly positive.
I would agree, I was there, yeah.
Yeah.
Oh, and I will say, if I can add, I did read the LAFCO document, and just for those that don't live in Chester proper or the Penn, there was discussion in the LAFCO documents around this can set a precedent for a larger consolidation in the Lake Alamo Basin. This will set a really good precedent for how it can get done. So not just looking at the annexation of the Chester service area, but also the entire Lake Alamo Basin, which has been discussed multiple times. But they're confident that it would set a good benchmark for it.
And then I think the Board of Supervisors approved a $50,000 loan to, I guess it's going to Peninsula to help fund
The fee structure.
That's
Right.
interesting, because that's not what they said at the meeting. They said they were denied
they were,
unless.
it was put up for the first round of votes and it didn't pass. And then Sarasola, who was one of the negative,
Changed.
changed his vote. He said he would support it if it was a loan rather than just outright gift.
Well, that's interesting.
So then they changed, they changed the language to say.
But I did hear from another source in the fire district that they do anticipate it being less than 50,000.
Yeah,
Right.
they said it.
And I think that go away some of their fees.
They did. That's what they, that's what
Right,
Jennifer said,
right.
like, be 30, so.
Yeah.
And I think even another thing is that it will dispel that urban myth that we've heard for so long, that the process takes years and it costs, hundreds of thousands of dollars. And now it's been proven that actually it only takes a couple of months and a positive working relationship. So,
We're very, very happy about this for the people of Chester to have an ALS rig and a full-time fire service here. Again,
How are interfacility transports working right now?
they're busy.
they're busy so far, and things have been going really well. And we still have not put our ambulance into service yet. It still needs a little bit of mechanical work before they take possession of it, but that is also going to be immediately available to them. And now, if they are acquiring those assets, our biggest expense was going to be that defibrillator. And they should have enough to go around for the vehicles that they'll have available.
Great.
So that's really great news.
Yeah.
And we'll make sure that the few missing items that were identified in our inventory, we'll make sure that those are there. So the only thing that they'll need to outfit it with will be that defibrillator. when they
Right.
receive
I'm
it.
very pleased to see that they both recognized West Shore's contribution to the mutual aid, because it's been a lot of mutual aid.
And then, just one more thing under EMS updates. We had another meeting this morning. We've been working with the county. They have been trying to create an updated MOU on the management of 5150s between the county, law enforcement and the 3 hospitals. And it's not been a smooth transaction.
Is this not
And-
surprising?
And so they were trying to create the MOU with all of the players. But, PDH dropped out and said, we're not signing this MOU. And
What
so,
was the biggest concern?
there were many concerns and they had been working with BBK. BBK had additional concerns. I got the California Hospital Association involved. And we met with their group and the 3 hospitals this morning, and they outlined what it is. And urged us not to sign this MOU until there's a better understanding of the new laws that are coming next year, et cetera. So hopefully.
New laws, I'm sorry, but new laws relating to changes in welfare and institutions code, 5150?
Well, it's not, they're actually not new laws. It's more of how we apply our EMTALA laws that
Okay.
are already in place
Yeah.
with a little bit more teeth in what the county can and should not do in their involvement and them understanding what their involvement actually needs to be, both financially and otherwise. So it's contentious. It is in every county. It's a broken system, but more and more the county has been asking the hospitals to take on more and more and more of what is actually supposed to be the county crisis unit taking in. And the hospitals do not have more resources than they do, so.
Yeah.
So anyway, more to come on that. And so we will be drafting sort of a letter from the hospitals with legal to the county legal. Kind of pushing back that
Outlining the requirements of county behavioral health per law. These are the things that you by statute will do. And you can't push them on us. In fact, you can't. You have to be able to do these things. So it's gonna be a reset. This is the only way I can look at it, is it's gonna reset the whole kind of dialogue, put us all on the same page. So everyone's aware of the information, same information, and then we'll see what we can come up with.
Yeah, there's two major problems in this whole thing. Historically, one has been the availability of psych beds.
Yep.
And the other one
Still
is local providers to do evaluations and get the process going.
Yeah.
They can't.
And I have to say that, we're currently using, we were using the telepsych, but using the county crisis workers up until just a few months ago. In July, the county contracted with a new telepsychiatry group, and they give us the published schedule each month, so we know who's on call. So we're still using telepsychiatry, but we get an actual psychiatrist on the unit, and they're either upholding the 5150 safety or creating a safety plan. And that's actually gone pretty well, knock on wood, so far. Thankfully, we don't have a huge volume of patients in psychiatric crisis, so but that part has actually been going well, but once it's decided or determined that they need a bed, we're back at square one as
Yeah.
far as waiting. We had a patient that was in our ER for 118 hours.
Have you inquired to the county how many inpatient facilities they're contracted with?
That's what I was
That's
gonna
right.
ask. Where are they? Where's the closest?
The closest one, I believe there's one in Reading that we
Yeah.
can sometimes find a bed, and otherwise they're down in, more in the Santa Rosa area.
What
Where
about
was it?
peds? Do we get many?
Rosa.
Heritage Oaks?
Yeah, do we get many peds psych? Thank goodness.
I mean, I think that would be one of my pushes, is for them to contract with more.
Well,
That
and
is one of our.
one of the interesting things was that, Plumas District has been successful in finding their own beds in non-contracted facilities, and what was driven home today was that the county cannot deny those because it's EMTALA applies, this is
Right.
considered an emergency, a
Right.
non-stabilized emergency.
Right.
Exactly.
So.
So the county then negotiates the contract with the
They
non-contract.
can take it from there once the
Yeah.
patient is in the psychiatric facility. If the county wants to try to move them to one of their contracted facilities, that's on them.
Right.
Not on us.
Yeah, it's interesting how they were basically saying that if you are finding a spot to put them, then you're paying for it. Well, no,
Yeah.
no.
And so,
We went through that too.
We gotta get them placed.
Yeah.
We gotta get them placed, and then the determination from the county is, can we get closer, those kind of
Well, the
things.
pushback is simply because they don't want you managing their budget for that.
Well, they don't wanna send them down to Malibu. That was one of the things they said. Don't send them down to Malibu,
Yeah.
California.
yeah, you're gonna bankrupt.
It's the only bed.
Bakersfield before.
You know, and so it was very nice to have, California Hospital Association on the group chat, today, because they do have, several members that are
Behavioral health.
very good experts in behavioral health in California. And we're able to confirm everything that we believe to be correct as far as the way things should be managed, and not be managed from the sense of the finances, but from the patient and his needs.
Right.
Yeah, so, I think it was a very positive meeting. We'll see what comes of it.
Good to have CHA, roundtabling with you
They're
on.
really good.
Yeah.
So we think the letter will come next, and then after that, another meeting?
Yes. Yeah, so, CEO of PDH is taking the lead of drafting a letter, running it past CHA and the 3 hospitals, and then, we will send that back to county council, so council to council, and then go from there. They said it was really unusual, CHA being they, that there would be even an MOU with the county, because the county has responsibilities, and the hospital's responsibility is medical clearance, medical screening, we follow EMTALA, and then we keep the patient safe until they're either, released or transferred to a psychiatric facility, so. Anyway, so they thought that was very unusual, to have an MOU about all of this, because it almost becomes like a legal document, and so, anyway.
So Judy, if they're cleared from our ER, medically cleared, and they need to just go to an outpatient crisis unit, 9 times out of 10, can Plumas PDH take them? Or there's no place, there's no county crisis unit or?
So the county is obligated to have a crisis unit and crisis workers available. They're only available from 8 AM to 2 PM.
Services.
That's not right.
And they're,
They don't to this side of the. And that's why we have to tell us set up to begin with, they will not come over here. And so if they're, if it's deemed that they are safe to go home with outpatient follow-up, then all we have to do is make sure that the county is aware that that was the plan and that they're being released, and now it's back in their ballpark to deal with the outpatient therapy. Because there's nothing here.
So The MOU. My day, when I was a mental health director, we had MOUs with the county, the hospital,
We said if there is an MOU or a letter of agreement is much more common language of how you kind of spell these out, or a policy guideline. You have to make sure that it's not just the county law enforcement and hospitals. You have to have EMS involved. You have to have your LEMSA involved. You need to make sure that everybody who plays a role in this is part of that MOU. And so what they were trying to push on us was, since PDH pulled out, that it would just be an MOU between the county and law enforcement and Eastern Plumas and Seneca, and left PDH out. And the way that the document was then spelled out looked like that Eastern Plumas and Seneca were the only facilities capable of receiving 5150s, which I said, oh, no. There's a third hospital. And so that was part of the contentiousness. Like, no, if someone looking at that document would think, if they didn't know any better, they would only have 2 hospitals to choose from when transporting 5150 to a hospital destination.
that's likely why it was easier for us in Lassen County, because there was one
Correct.
hospital.
Yeah. Anyway, more to come on that. That's it for EMS updates, nursing and other workforce concerns. Let's see, we did receive notification from partnership that Seneca was awarded a $50,000 scholarship that we applied for. And we applied for that specifically for the recruitment of Stephanie White, nurse practitioner. And so that will be paid out. And that will help her be able to pay off some of her student debt. And so that was really great news. We applied for it months ago, hadn't heard anything, had a couple more meetings with partnership recently. They kept bringing it up, like, we applied.
I didn't know they did that.
And then a couple days later,
That's
they came
amazing.
back and said, hey, guess what, you got it. So
That's
that
amazing.
was
That is
great.
amazing.
Registry travel staff, I had given Steve an update earlier this week because our budget was looking a little off during our treasurer's meeting, and wanted to make sure we were on the same page. I'll just give you an update. Currently in the emergency department, our final contract just ended on October 26th, and so we have all permanent ER staff right now. So we hired a permanent night shift RN, and we have hired 4 per diem RNs, that 2 of them are for the ER and 2 of them are cross-trained between acute and the ER. And in the 3 years that I've been at Seneca, we have never had this staffing.
That's amazing.
So I hope we can hang on to it. I said it out loud, so someone's gonna get injured or get sick or something, but acute care, we have 1 travel RN on night shift through the end of the year, and that's just because our new grad RN is finishing up his 6-month orientation, and then when he's done at the end of the year, he will slip into that full-time night shift slot. And then we'll only use like an occasional registry fill-in gap coverage. That's usually an LVN that we.
Judy, are the ER nurses, are they MICNs already?
Not yet, because a lot of places don't use MICNs. But we are going to bring back, NorCal has already offered to come back and teach another MICN class, so they will all be MICN,
Great.
yeah. Thanks for asking that. And then long-term care, we were down to not using any registry until I sent Steve that report yesterday. And then we had a CNA go out on medical leave, and one who submitted her resignation because she needs to take care of an ill family member. So we're down a couple CNAs right now, but we think we can overcome that. And then Tessa's been very busy also recruiting new residents for our openings in our long-term care. So we have an approved female and an approved male resident that will be joining us probably next week, and that will bring us up to 100% on our census. We are still using 1 clinical lab scientist. His contract expires on November 22nd, and the permanent clinical lab scientist that we recently hired will be finished with his training and move into that So that only leaves two phlebotomists, that, we're having to cover with travel staff right now while they're out on medical leave. When they come back, then we will have full staff again. Regulatory activity, we are still anticipating our annual long-term care survey at any moment. Typically, they try and come up here before the snow falls, so it should be any minute now. And,
Already found Westwood.
what's
I
that?
had snow in Westwood last
I saw
night.
the mountains.
Yeah.
It snowed everywhere except my house, so.
Thank you.
Anyway, that's all for my report. If you have any questions?
Thank you.
Thank you, Judy.
you very much.
Good work. Congratulations on your.
Yes.
Yeah, it's not too exciting.
All right, I think we have, Brady, you're up for your CO report.
Yeah, so I have, quite a bit in here, listed some highlights, and something, a project that we did together. With certain services, so we're gearing up for. Kind of the new process and surgical services for the new facility by really, kind of understanding where we are and, our staffing model, our efficiencies in there. The staff's doing great. With the clinic process improvement of colonoscopies and all of those things from getting people to do it, you have to have that efficient OR to do it. Which goes from the philosophy of department philosophies to services. And so that's where it's continuity of care from start to finish. So Judy and I have accepted those processes with the team, great team that we have there. So that's something that's not in the document. There's a lot of things, as I've said before, we're getting into our winter months and winter projects, and we're with revenue cycle, going back to the basics of phone calls, all the basic steps, making sure that our systems are working, our processors are working, answering their calls. So some of the basic stuff now, it's quieter, but it's still not there. Because if we miss one, we're not there. But with Brian's help, we're getting smarter because of the IT brilliancy that the team has, so that we can capture those patients and get back to them. Radiology, really Linda's area, the clinic area, we touched about Linda's area, everything is going well. Her team is preparing for winter because they're impacted the most.
I'm gonna ask about this for snow this year.
Yeah, so, because of lack of snow locations in the contract that Linda put out, their hauling away snow is one option. So once everything settles, like this fence gets removed, we'll kind of get what we can store here and what has to be
So
taken.
will they take this fence down?
No, not this fence, but that little fence over by them. Once they get that, but
Next week.
Wait a minute.
that is top of mind with the weather that we have. So, but Linda and team are handling that. She did bring up, she had one retirement and one person to another organization, but we did bring a very skilled person on, good fit, and so that will help us through the winter, all the activity, because they get pretty busy during that. Radiology numbers, they're all here. We're starting to put more graphs and numbers. So you're starting to see this. This is Candace, our clinical informaticist that is great with all this
You
stuff.
can build, you can tell her that I really appreciate the graphs, so.
Yeah, we still, I mean, and the thing is, we're just starting, there's still a lot of work, a lot of things to improve the numbers, bring the revenue to Steve.
Yeah.
And all of that stuff.
Can you tell us the difference between the discern analytics and the lifetime?
Yeah, I'll get to,
Sorry, if I'm making you skip ahead.
well, on the, just the MRI, one that, as Sean's saying, there's like two plans. There's short-term plan and there's long-term plan. Long-term plan is if that's the board's pleasure, owning with the other organization. Short-term plan is getting a company, and we've had discussions with the group on a company. We've looked at a couple, and there's one company that's at the forefront to get them to turn back on services somewhere between January and February. So that way we're up in MRIs, and then we're looking on the long-term plan.
Would they park that here or would it?
We
still
would
be-
still be in a route system, but we're thinking, based on numbers, and we have to do the business case for all of this. But more like once a week, because when we're doing it, every other week, if one cancels, it's too far to schedule. So we're gonna, all the hospitals are kind of looking at what they currently do, and decide what we should do. But we're gonna work with, a current company for the short-term plan to get it up and running, and then long-term solution. So that's a little more in the MRIs.
So where are we visually referring patients to now for MRIs?
Well,
Enloe?
well, there's around us, but probably the closest one is Banner, but we heard last week it went out.
Yeah.
So there's Reading has a couple of facilities, Enloe has a couple of facilities, Reno has a couple of facilities. It all depends on, do they need 3T, what they need and all that
Right.
stuff. So, we're handling that, but it means patients have to travel. And as we get into the months that we get into, that's harder to do.
So if we go with this company for the short term, are we looking at doing a contract that includes the other facilities
Yes.
to enhance our buying power?
This is actually it's gonna mimic the route that we would own.
Okay, yeah.
So we've been in conversation, we got 5 facilities to say, okay, we want a dedicated route.
Okay, good.
For in the interim and then determination around our own.
Yeah, because for a service to do that, and even if we did it, it needs all of us to make it sustainable.
Yeah.
Right.
So no matter how you do it,
Right.
all of us have to be in on it, so.
Yeah.
Okay, so the last page. So, there's a couple, and I'm gonna start sprinkling these. This is just the tools that we have to look at. These are sample numbers. So there's, what we call the DA2, and it's reporting capabilities. We gave you a little kind of what it does. And so that's more the day-to-day kind of data. And when the data comes out, you have to extract it, and it's not necessarily on a dashboard. You have to build the dashboard.
But it connects directly to Cerner.
It is.
Yeah, this is all,
It's
these
all
are all
owned by-
tools
yeah,
in Cerner,
Okay.
yeah.
Yeah.
And then there's lights on, and then there's advanced, the next section. And in here, these are more built dashboards, and so it's pulling the data, you give maybe a date range, that kind of stuff, and put parameters in there, and it pulls the data.
I have to say, excuse me, I have to say something.
Also, what kind of macro do you use micro?
Yes,
Yeah.
very detailed and detailed.
Right, so when I was reviewing this, I'm like, what is her interactions with her? And I'm like, so I'm Googling Oracle and
EHR.
Lifeline Network and her, and I'm like, what acronym is this for? And I'm thinking, oh, it's gotta be EHR.
It always converts it. It
I
converts
know, I know. Sorry. A little humor.
Interactions with her today.
So you can see in the second group of tools, you can have performance metrics, like, so for operations. If I'm looking at a clinic, I'm looking at how many patients per hour, how many patients per day, turn rate, in between, all of that stuff. If I'm looking at in the surgical services, I'm doing similar thing on the throughput of the patient. From the clinic visit to, discharge, the process. And I'm looking at how long were they in the OR, what's the turnover time in the OR. All of those kind of things that I would look at in detail from an operational standpoint. Just so I can see efficiencies or where we can, what's the data telling me, and then I go and visualize it. I look at the efficiencies, because some things, it's the staff are going as fast as they can safely, good quality care. But what occurs is there may be a process, like they only have one of something. And so one of something, to
Right.
turn that around over and over again, you know, so there's those kind of things, you take the
Right.
data. And you go look at the process and study the process, then you make your decision.
Right.
You don't make your decision off the data,
Yeah,
because,
right.
you know, there's all this. Now, the other thing in this data is as, you know, we're over a year, so this is the perfect time that the data starts to come true. And so when we start, you know, putting that data out, because the end value is getting bigger, we're getting more patient touches in there, we're starting to understand the system. So as we start bringing stuff forward, we'll see this data. Early on, it's with a grain of salt, but as we, you know, kind of refine it and we double check it by visualizing, say, yes, that's true. Then we'll get more confidence in the dashboards, and that's the evolution of this next year to start looking at that. The one, in the Lights On network and the Advance. The fun thing in the Advance is, if you look at the little box down where the whole bunch of colors are, circle colors, but below that, it's one of those, if you've ever been to a meeting and everybody puts their input and it pops up on the screen, oh, there it is. Pops up on the screen on what's everybody's, you know, like, thank you, this and that. And so you can do that in there over the clinic visits to say, what are people coming in here for? And the bigger the words, the more, you know,
Yeah.
data points are behind it. So it has some really cool tools. So as a board, now I know, Rich, we have zip code analysis and we have figured that out. It's just how we want to look at it. But as a board, I think, what do you want to look at? I know what I like to look at. Steve's got his stuff, John's probably got his stuff, and Judy's got her stuff, but as a board, what kind of dashboards would be important?
For you to see.
For you to see.
Yeah,
And noodle on it, we're not looking for an
Yeah,
answer right
so
now.
just think about it.
Something I'd like to see at every board meeting.
Yeah,
Yeah, or if there's any, canned ones that you don't have to spend too much time on, you could always send you
Yeah.
out to us, so we can kind of
Mhm.
see, well, maybe something like this, but maybe a little more like that.
yeah, we're gonna start
Tailor it for us.
putting out
Yeah.
examples, just to kind of get everybody's mind on it, like, does this help us, does this not? Yes, we like that.
And you guys might have to tamp me down because I like data, so.
Well, you know, the nice thing is, if you want to see an added, field in it, we can tweak it. It's just, what it does is it gives you sort of, I like the lights on concept. Lights on meaning, you have visibility to the organization. You could have in real time. It gives you a better understanding of what we're talking about. When we say, hey, this is what's going on, you can look at the data and go, well, there it is, it's
Yeah.
trending, you're right. Or perhaps, hey, why is this trending down? And we'll have the answer because we're watching it too.
Yeah.
We can tell you why certain things are happening.
Well, to the point of, what kind of visits people are coming in for, that's something that I'd be very interested
Yeah.
in, because, maybe there's not very many people coming in for a certain type of visit that maybe we need to be educating people on the fact that we have the availability for whatever that
A
is.
great one that I like to look at is who's establishing,
Mhm, that's
right?
true.
That's a new patient.
Yeah.
It's who's an establishing, that actually establishing with a doctor. I love that stuff because it tells me I'm that new.
Well, and to that end, out migration.
Yeah, out migration is a little more difficult, or you can run something to show me who has not been here in a year and a half, and then why. We don't know the why, but we can find out the why.
Mhm.
Why have you been here?
Maybe they moved.
Where are they going for?
They
Where
move.
are they going for?
this conversation seems like it
Yeah.
might require a special meeting just to familiarize ourselves with the range of
I mean-
possibilities here.
Well,
Those,
yeah, what I'd like to do is, because there's so much data, like, it's not just, an hour session.
So 600 plus metrics.
Yeah,
Wow.
so
is,
there are dashboards that I've brought to boards before. And so what that I think are important for you to see. And so we'll start in every board meeting in this document, we'll start to throw more analytics. And then that way you kind of get, and we'll do this over this next calendar year. And so you can go like, okay, yeah.
We find out through that process what's most relevant. for
Yeah,
us.
I like this. Yeah, that was interesting. And
That's a good
then
strategy.
it's gonna, you know,
Yeah.
birth some ideas of, well, if we could see it this way. And that way, cause it's like when you go through here, it's like drinking from a fire hose. I mean, you have so much data, and you can spin it all different ways.
You'll be in heaven.
Yeah,
Are there other critical access Cerner that use, critical access hospitals that use Cerner that have, user groups that are currently,
So
Just
far.
working on this?
There are benchmark, you can select cohorts that are similar to compare.
Yes. like national average when you've been.
Yeah.
Yeah,
So you
there's,
take critical access, rural access, you can.
Yeah.
You know, so you can get a cohort that's similar
yeah,
to you.
and
Interesting.
in the reports, I like that
That's really
because
interesting.
Yeah.
are we good, are we bad? I don't know unless you compare it to something.
Right. right.
Cautionary tale on cohorts,
Yeah.
the cautionary tale.
They're
They can be
different.
very, very misleading. Because while you think you're very similar, if they're one data point off and it skews it, you can start scrutinizing your own organization. And really start to dive in on it. It's one ridiculous little thing that matters not, but it's part of the database.
Yes.
So it's just, I cautionary tale to all boards, when you do comparative analysis, it needs to be comparative analysis. In other words, it has to be apples to apples, or you will freak out sometimes.
Yeah.
And I've
Yeah.
But well, like Wade was saying, we can set our own thresholds.
Correct.
Yeah.
On like,
Yeah.
I don't think this board would freak out. I think they'd go, okay, how come it's so different?
Right, I think it'd be fascinating.
I just tell you, in my prior life, they were all driven by market analysis and comparisons, and I'd spend hours and hours and hours figuring out why there's such a delta between the two, and I'd find it and be, oh, they do this.
Right, or our volume is.
Yeah, so it's just,
Well, and
in
that's
the data all
why
day.
data is data.
Mhm.
You go in and watch, you go in and observe, you can see, because
Validate.
everything I ran, or I.
Good data and bad data.
It's, yeah, it's, you gotta have what your gut says, what you visualize, what the data, all of that together to make those decisions.
Right.
What you're hearing from your patients. So this will be this year, and we'll start to roll stuff in with, which will be a great discussion. Steve's, you know, from his financial lens, I mean, is a ton of data that is also tied with this throughput, all of that stuff. So there should be some correlations as we build these things, you know. So anyway, more to come on that.
That sounds really good. Virginia.
And then, just the last page, these are some of the projects that we talked about in the winter months. Candace is leading those, projects with myself and JJ and Judy. And so you can kind of see what we're, working on.
I like being able to see the referral process.
Yeah.
And see how that's working. That's a really good thing.
Yeah, there's some basic ones that I think would be, you know, and we'll start slow and slowly walk into
That's
it.
one thing that we had challenges with.
Yeah. Yeah.
Oh,
Vision board 6 months ago. Yeah.
Provider wise, only, one change is we talked about Stephanie White. She's gonna be starting December 1st. She will be in Dr. Ware's office. She's gonna be working with Dr. Ware for 2 days. She's gonna, still manage the nurse educational role that she's currently in for 2 days. And then she'll have 1 day for her practice. And we're gonna start where she builds, and as soon as that day is full, then we'll go to another day and slowly walk into building a practice. And
Okay.
that's my report.
Sounds good. Thank you. Any other questions for Brady? Thanks, Brady.
Thank you.
Okay, looks like Brian, you're up next.
All right, so today, what purchase is supposed to be from?
We're supposed to be.
All our what?
Printers.
Well, upstairs, the, video was not yet, yeah, I'm sorry to do that. We, vacation, I think, from kind of okay, but it's not making that change. But as we focus on the winter projects, we're looking at operational costs right now. So one of the big things that has changed over the last year is a company called VMware, it's virtual service in the background, the company bought them. They terminated perpetual licensing and went to a subscription model. As everybody's doing now, so they constantly have a cash flow. The initial quote was 4.5 times what we budgeted, but we're able to look at what we really need as a facility, get it close to what we had budgeted. Looking at that same type of tools with the Microsoft Office suite, we have in the past, Slate has purchased a full office license for everybody. For the most part, it's not needed, except Microsoft has built it so that unless you use SharePoint, you have to have the application installed on a PC to get real local network traffic.
Of course they did.
So that's one of the things that drove us to move to SharePoint. We're already licensed for SharePoint. So we're gonna move over the winter time to SharePoint.
SharePoint's a great tool.
And then we will transition probably 80% of the workforce here to the web version of Office. So we'll still have Word, we'll still have Excel. It'll be the web version, and it will go from $22 a month to $8 a month per person. Those are the type of things that we're going to focus on this year. We've got a couple other projects that are in the budget. With the cash flow issues right now, we're looking at timing in those so that the invoices are coming in, so the cash flow is appropriate for us. But we can do a lot of the prep work and get them all started up. Butterfly, fighting with invoices, not invoices, ordering process. I need an order catalog now to build. We have all the iPads, he's finished all the iPads, so we can start looking at the usage and training, and do we want to deploy those as a diagnostic tool, but not built for them yet, get used to it, while building the interface, but we're moving, very quickly in that place. With that too, on the iPad, we've also, been able to convert the, long-term care to an iPad for the CNA, so they don't have to use, they can bring it in on a sealed laptop, sealed iPad on their hand, and do all their documentation in the room, and not use, laptops. One of the other projects we have coming up would be, it'll be a labor intensive, but not costly, is we need to convert from Windows 10 to Windows 11. We have all the licenses, now I have the staff, we don't need to contract Apex to do that, so we will, they can do that internally as we have very likely will grade those, not swapping them out, so, we'll be busy during the winter time, doing that stuff, but doing it internally, not charging out to Apex. And then our final thing is our Apex contract is due at the end of March. It's a 90-day window that we have to notify them. Brady and I are working on what we will actually contract with them for next year. We hope to peel back at least 50-60% of what we're paying them back to our HRs.
That's good, thank you.
Busy.
Lots going on there too. Any questions for Brian, guys?
No.
Thank you, Brian. Appreciate it. Okay, next up we have HR Jenny. Is Jenny on? Hold on here, this is gonna be her last meeting with us.
So in her last.
Yeah, Miss Jenny. She's not on, oh darn. Okay. Well, I didn't have any specific questions. Her time with us and doing such a diligent,
Yes.
thorough job and staying on until we have a HR director and all
for sure.
that, so.
Sean's on in 2 weeks. She has had pre-scheduled vacation today until Monday. And is getting absolutely digging in, 100%.
That's great. So I just want to say thank you to Jenny.
Yep,
So
thank you, Jenny.
sorry she's not here, but hopefully.
Do you want to send a card?
Yeah, I would love to.
Give her
Mhm.
put that together.
That would be wonderful.
Yeah, that would be
It's a good
great.
idea.
Yeah, we could all sign it. That'd be awesome. Thank you. That's a good idea.
Nice to give her some recognition.
Yes.
Mhm.
So, and does anybody have any questions about the HR report that maybe another staff member could answer? I like to see it's in the newsletter. There we have. Very well written. Let's see, okay, so then I guess that moves us on to marketing and PR. And Chelsea had some scheduled vacation, so she's not
Yeah,
here.
Chelsea is also seeing.
Not that I had any questions specifically for her on this. Did any of you? No? Okay, and there's no compliance, it's like our next quarterly compliance report will be at our next board meeting. And I think that brings us up to
My next newsletter story is gonna be what's an interface?
What it is and what it isn't.
It works, it's great, it doesn't. Nobody's saying that.
like a not very fun story behind that one.
Okay. So what y'all have before you is a little catch up on financials. So I did the 2 months ended August and the month of August. And it's unfortunate that I did it that way because July was about a perfect month for us. Revenue was as high as it's been since I've been around. So that was very positive. We managed our expenses reasonably well. And we had, without any of the supplemental stuff in there or any other items, non-recurring items, we had a very low loss from, I should say, net loss margin. So like Sean talks about trying to get to a zero, it was right around 10%. So that was also very close to one of the best months I've seen. It was driven by a few things. We did see very high volume outpatient utilization, both in the month of July and in August. Not as much in August as we did see in July. But it is a little bit inflated, if you will, because we started doing wound care services recently and doing wound care through the use of skin substitute. I don't know if transplant's too big of a word, but it's basically putting the skin substitute on there. The skin substitute is very pricey. And so we generate significant charges. If you look at the outpatient revenue analysis in the back of the financial packet, it'll show a very large amount in central supply. And that was all from this product that we're using.
Is that Dr. Jensen doing that primarily?
Dr. Russo.
Yeah, Russo.
Oh, Russo's doing it?
Together.
Oh.
Yeah. And it's been primarily with a Medicare patient. And we get paid very well, believe it or not, from Medicare. And so it's a profitable procedure. We have since accepted or brought in a Medi-Cal managed care patient, which we're not going to get paid as well. So it's just something that we're going to have to figure out how to balance and manage that. So
it's not a partnership patient then?
it's a partnership patient. I mean, they all pay the same.
Yeah.
So I don't want to single them out like they're bad guys or anything. They pay us what they pay us. The good news is that when we talk about supplemental payments and the cash flow and later in my presentation, the driving revenue, driving utilization through partnership, through the HMO managed care is going to be very significant in the coming years, because it's going to dictate the amount of supplemental payment we receive. And when we get out to 2025, which will be paid in 27, there's a proposed projected huge increase in the pool that's available for distribution. And so it's critical that not only do we want to capture our service area population, which includes a sizable amount of partnership Medi-Cal managed care. It's good business when you look at it that way.
So is partnership still 18 months in the rear for their quality reimbursement, metric reimbursements? Or is it longer now?
I'm not involved in that part of it.
That's big
As far
money.
as the QIP program, no,
Yeah.
that's tracking.
Okay.
You mean like, as far as they're using data
And then they're paying that, 18 months is about right, I'm
18
sorry.
months, yeah, okay.
They are collecting data, we have requirements.
Yeah, good.
That's why we say that 2017, the payout in 2017 will be using 2025 data. And that's the program year that's going to have a significant. if it's,
Payout 17?
27.
Oh, okay.
Yeah.
Gotcha.
We'll have a significant increase in the funding. Like I said, unless Elon Musk gets in there. Department or government efficiency, and he whacks $2 trillion from the budget, so. So after that huge preamble, the bottom line is that through the 2 months, we had a net loss of $410,000 versus a budget loss of 357 for a negative variance of just $52,000, so that's great.
Well, we also wanted to note that the area was closed due to the fire during the
That did
same
affect
period
us,
too.
our volume did go down for Park Fire, for sure. I mean, but August probably would have been a lot better.
Yeah, it's pretty ugly for a little bit there, that's for darn sure. So the negative variance we had there was driven by two things, that our total operating expenses, so getting a combination of July and August. July was pretty well managed. August had some larger variances that we can talk about. And it was offset by this positive variance in patient revenue. Gross patient revenue for the 2 months ended at 5.22 million versus a budget of 4.7, so positive variance of $515,000, which is obviously very significant. And this was due to a combination of a positive variance in outpatient revenue of just over 600,000. I think I talked about that a little bit. In the month of July, we had really high volume because we not only hit our number in the clinic as far as what we projected, and that was adjusted for seasonally adjusted, so what we would expect during the summertime. We also had a excess positive variance, if you will, in the utilization of the emergency department. So the outpatient services in July were robust, to say the least. And we handled it, managed it very well, and it's something we can talk about as well. On the other side of the coin, inpatient, as of July and August, inpatient was lagging behind budget. I think we've seen a little bit of a jump in it recently, but that's still an area that's lagging behind as far as what we budget for, which, my goodness, is a very, very small amount. That budget of 31 days for inpatient is 2 months, so that's a half a patient a day. So that's a very low daily census, and swing bed even lower, a quarter of a patient a day. So as we show there, the average daily census was 0.35 patients per day. So there's where some opportunity is. The problem is, of course, is inpatient care. You can't predict, you can't recruit, you can't. It is what it is. It happens when it happens, but it's our ability to be able to manage it when it shows up. So
Steve, it goes back to that stability of our hospitalist stability and our willingness to admit and follow. So I think that we're really focusing on getting that stability going. Sorry, Steve.
No, that's a conversation we need to have. So
I have a question. So how often are we having to transfer patients to other hospitals because our ER physicians that we have on staff will not or cannot follow?
So
in
let
the
me
inpatient?
give you a non-answer. Because I don't have a great answer for that. I can tell you this, that the hospitalist side of the ER hybrid model is not something that every ER doctor in the world wants to do.
Yeah.
I can tell you that we can keep a lot more people. We can keep people that we are sending out. And I think that without any sort of analytics, anecdotally, and I'm speaking with our chief, they're sending things out so they don't have to manage them, even though we could easily manage them on our floor. It's really I don't want to do that.
Well, Can also preface that by saying that I think that part of that has to do with your staffing that you have and what kind of level of trust you have with who you have there to take care of the patient.
And we've been building on the
So
nursing
kind of a
staff for a period of time.
Yeah.
I really believe that's our next push point. You know, I mean, we're gonna constantly work on our outpatient side. You see here that there's gonna be a big outreach. I think that solidification through the winter of our ER staff, nursing staff, that keep them, not keep them, that if then statement, you know, what we should always keep. So we're doing something similar to our trauma. So there's what they call red box. Anything that is in that red box goes out immediately. There's yellow box. The yellow box is, we should be able to keep them based upon certain criteria, and then there's green box. And we literally want to make a visual up there for our doctors to say, if a person presents with this, aside from any other comorbidities that medically you feel are dangerous or something else, we're keeping them. You know, keeping in mind that we're not gonna put anybody in danger.
I think the only way to get to the answer to your question is to actually go through case by case and review every case that got sent out. And that's the only way to do it, really.
It really is, and I do think that a lot of it's going out unnecessarily.
Well, that's out migration. I mean.
That is,
It is,
so
Yeah.
it's opportunity for sure.
Yeah, and it's a holistic view. It's the, provider's decision. It's the
Trusting
patient's,
the nursing.
trust in the nursing. So as stability and all of this goes forward and the community wants to stay here, like, no, I'll stay here. That will build. And I think as we look at the months forward, we'll see some trends because we're
More stable in all of the staff.
yeah, we're
members there
seeing
now.
it
Yeah.
actually today in the last couple of weeks, which is creating another problem. But it's a good thing. So we're actually seeing,
How much of this is linked to specialty care, I mean, for additional specialty care?
well, the specialty care from a critical access hospital, if it's a broken bone, it's red box, it's out, or if it's an orthopod that can, you can stabilize it and get it to. So, from transfers, I would say it's, there's probably a little bit of specialty care influence there, but a lot of this is too critical that we can't handle. Now, there's the borderline where that's the trust and the decision where the patient needs to go, and that's probably more influenced by, what we control here, so.
Suffice to say that, Steve's financial report, hey, our outpatients crushing it, and look at our inpatient volume. Because that's really where we see the variance.
Well, because I think about, as a case manager, I think about like one of Dr. Ware's patients or one of Dr. Russo's patients that is in the ER and it fits in that yellow box. And we're transferring them out for whatever reason, who's following up with that patient?
Well, this is also.
Because if they go to Enloe could be referring them to their own ortho or to their own, for a GI or,
Yeah, usually, so let's say we refer that patient to Enloe for, if it was orthopedic, cardiac, whatever, they will take care of that, whatever that is. And then from that point, because the call system down there, they can see them in the follow-up clinic, but other than that, they're back to wherever they're established, their primary care.
So this goes back to building off of the specialty clinicking up here. We would like people to dealing with their emergency, their red box stuff, or their high yellow, getting taken care of, whether it's an intervention or procedure, coming back to clinic here. That is where we'll see an increase in outpatient volume as well, because we'll have maybe a cardiologist up here that's clinicking, or an ortho or podiatrist or an endocrinologist, those type. That's also in the future is more specialty outpatient care so they can revert back.
Well, yeah, that's what I was thinking.
Yeah.
You go to some MLO for a cardiac condition or
Yep.
who knows what, and
They put a pacemaker in and they
Well,
send you on your way.
yeah, because they're not established, because a lot of these areas don't have primary care docs. And
Right.
so it's not like they're schooling them in. The specialists can barely handle the volume they're handling. So it's like, they take care of you for whatever that is, like the call, and you're gone.
So do we ever repatriate back to our hospital, the patients that have simple wounds or whatever that don't really need to stay at Enloe
Type stuff.
or?
Yeah, most of them, after they take care of whatever that need is you follow up with your primary care. So if they're established here, they're coming back, we're setting appointments for follow-up. We get all their charts, their x-rays, and then the primary gives a game plan of what we're gonna do from here.
Seems like there's an opportunity there for education of our primary care physicians. In that, having just gone through some of these scenarios, I can say that when I saw my primary care physician, I said, did you guys get any other records from Enloe? Because I've never heard from you guys that anything came back here. And oh yeah, we got them. And at the time I thought, well, it seems like just the smallest thing, like a phone call saying, we received all your records from your visit to Enloe and your procedure.
Right.
And we want to let you know, that we need to follow up here.
Yeah.
And, so within the next couple of months, you might want to schedule a follow-up appointment in this office.
Yeah.
Because otherwise, Enloe continues to contact you and you're, if you're in their system, they're not easily
It's a great touch
letting
point
go of you.
for patients.
Right.
Great.
And where patients go sideways post-discharge is 7 to 10 days out.
Yeah.
So within that window,
Sure.
they need to, because they kind of
Readmit.
forget, what was it, all that.
Yeah.
That's that window that,
That's
when you
true.
look
Right.
at it, that's where the readmits come.
Mhm.
And so that's, that you need to get to your primary care, so that is.
Yeah, and even if it weren't the primary care physician themselves making the call,
Yeah,
their office staff could
Correct,
do a
yeah.
follow-up.
very good point.
Cause I think that's what we've been aiming for, is that feeling of this is, you're part of our
Yeah,
community
yeah.
and we're hands-on, we're gonna take care of
It's the
you.
continuity. of
Exactly,
care. It's the
yeah.
continuity of care.
Exactly, so,
Do we get dinged from partnership for readmits?
No, not like a Sutter or, Steve, you want to answer that, our readmission rate through the ER? If we kick someone out and they're back 24 hours later, do we get a beat down on that? We don't, we're
Not
not.
for Medicare, I don't know,
Not for Medi-
I
Yeah,
have no idea what
Partnership?
Medi-Health does.
yeah. It's not as draconian as say like a Sutter,
Mhm.
where you have to get penalized. So,
We get a per diem, per diem rate for inpatients as opposed to a DRG, so, it's,
Okay, difference.
that's where they, in DRG hospitals, they can't have admissions within a certain.
Oh my
period of time.
gosh.
brutal,
Oh my God.
So,
Oh.
I mean, if we keep doing it, it's gonna pop up on a pepper report or whatever they call them now.
Yeah.
And this is what they have.
okay, sorry, Steve, we digress.
No, it's nice that it's not just a groaning on of numbers and, it's a little more.
That's what we like this. that drawing.
Well, try not to be selfish. All right, so, Ethan, let's just take a little buzz to the next page. There we go. So here's this is what's great though about doing a 2-month presentation in the first 2 months of the fiscal year, year to date, less current month was last month, so kind of thing. So you really can't say, especially when we go to the statistics, because we disclose a report, right against it. So just kind of thing that I want to point out here is the idea of the expense management a little bit in the month of August, and probably one of the, you have a little pointer thing? So one of the things that hit us in the month of August was professional fees, medical, and there's a detailed analysis, again, at the back of the financial package. What we had during, it started in July, and it carried in, well, actually, one of the providers is still here, the other one left, last month or just recently, is that we have a core of providers. We have Heather Smith, a physician's assistant, and Lori Kohler, a nurse practitioner. Then we have Dr. Russo, physician, and then of course, Dr. Ware. So Dr. Ware call her half-time, call her 2/3, whatever you want. The other 3 are full-time, so we have this core group of 3.5 providers. Well, during, the summer, we brought in a couple locums providers. Dr. Russo was a locum. Brady was able to convert him to a permanent agreement with us, so a 2-year agreement, under contract directly with us. But we brought in a couple locums, for a couple reasons for the projected volume that we were expecting during the summer. And there were also a couple questions with, the providers we did have, as far as, you know, was Dr. Russo gonna renew, and then another provider might have to take a little leave of absence during the summer. So we brought in these other providers, so we had 2 more locums, and unfortunately, a little over $200 an hour. And so our cost per provider was very much higher, and so that pushed us over there. But what it did, it allowed us to see a couple things. Even with these high volumes, the providers were not excessively productive. You know, if that's not meant to be a disparaging word. Because when we look at our providers, we want them to handle 10 to 12 to 15 patients a day, a 20-day work month. So we want them all to see at least a minimum of 200 patients a month. And so with this high volume, nobody hit that number. For one, there was a bunch of them, but we look at that volume now, and we could get it with our 3.5 core providers. Now bringing in Stephanie White to help out a little bit too will be great. And so the idea now is to manage that patient demand in a more cost-effective way. And that's kind of our plan, so that we could have this level of utilization with a little less cost. And then we are darn near profitable from operations, which it would be an amazing accomplishment for Seneca. Again, the supplies were high, much more in July from the purchasing of the skin substitute, which in turn translated into revenue. There was also a purchase of pharmaceuticals, we had a little run on rabies, back bites or back exposures. Very, very pricey stuff. And that again, also, if you look at the outpatient revenue, turned into a high positive variance on pharmacy revenue. So again, there was good, just overall outpatient demand, but we also had a couple, you know, one exposure to a bat and whatever, and the utilization, it's like a rattlesnake, you know, if someone has a heart attack and you give them that stuff that saves their life, you know, the use of things like that, that's not gonna happen every month. So the other area is in salary. Basically, let's just call it labor. So we have salaries and wages, which is our W-2 employed staff, and then we have contract labor, which is the registry staff, nursing, and lab are the 2 areas that use registry staff primarily. So we were a little high on expense, spent some time with Judy, and Judy looked into it a little bit to determine, you know, why are we over? We've never really run at this high amount of total FTEs. And there really was a bit of a timing difference of bringing on staff. And I tell Judy, I tell Tessa Parthens, I said we could never have too many nurses. It's just, that's not possible. So when they find a nurse that they can put to use at Seneca and will make a good contribution to us, we gotta grab them when we find them. So
Even if we have a contract with a registry, it's still under contract, we just let it run out, but you don't miss something.
and you know, don't say come back in 2 months.
Right.
Sorry. So, we are gonna continue to dig into that. You know, unfortunately, I haven't been able to spend the time that I would like to have, working directly with the departments on, their budget, management. Worked a little better with them this go round on the actual preparation of the budget, but still more to do there. So that's one area we're gonna be following into September, October, especially as our volumes go down. Maybe some of this was in response to the high volumes, especially in the ER in July, good gracious. Very, very busy. So that's kind of the story there. There's a little bit of a negative variance on adjustments or net patient revenue. We budgeted 70% for our net patient revenue percent. We're running a little over 67%. That's just due to the aging of the accounts receivable a little bit. It is improving and it improved into September in the report that you all have. But we're just keeping a little extra reserve just as AR ages out. Just by definition and rule, the collectability of it does diminish a little bit. So that's the financials there again. Positive patient revenue, boy, haven't said that in a long time. Expenses were over, we can kind of live with that. And then we did receive some donations. Our interest income exceeded the projected little bit. And so bottom line, again, for the 2 months, we were negative to budget. Bottom line, 52,000, so we're gonna call that good. Questions?
Thank you, Steve. Board members, questions, comments? All right, should we take a motion to accept the financial report?
I move to accept the financial report.
Thank you.
No need for
Do I
that.
have a second? I second. Thank you, Sharon. All in favor? Rich, you're on, yes?
Aye.
Thank you. Ken?
Aye.
Sherry?
Aye.
Shelley? And I'll vote aye.
Okay,
Thanks.
real fast, if you would go to page, probably like 4. Yeah. Okay, so one thing, and I'm just gonna say this because we're gonna probably have another meeting here in the very near future to talk about what I'm gonna, or to go over what I'm gonna talk about next. We have some historical thing where we had designated, the board had designated funds, rainy day fund, capital budget funds, and those funds, whether they're designated by you guys or not, are truly needed for operations. So I'm gonna, when we meet next, I'm gonna come to you and ask that you guys undesignate those funds and that we use all funds available for paying operating expenses, and then the reserve we have for the IGT be used for that purpose as well. So anyway, that's just a heads up there that you'll see that difference there with those numbers. Where'd those go?
Yeah, and you can argue that we've already spent well over that with our down contribution to our new facility too, so I
For
think
sure.
that makes sense.
Sure. So, Ethan, if you would go to, is cash flow next?
Yes.
Yeah. Rotator.
Okay,
Right.
sorry, I'm going back to page
Oh, wait.
5 for a second, Steve.
Hey, what?
I'm going back to page 5, we're down to 0 balances in all of our loans and. all
Yeah,
our
at least we
leases and-
got the pink slip on the CT machine.
You wanted to make that's wonderful.
I've seen that before, that it doesn't have a.
No, if you click not that, yeah.
No, that's reloading the paper shot.
Oh, there we go.
Yeah.
All right, you, I hope it's, yeah, there it is, right up at the top middle, automatic zoom to the left is the plus. You can just, I know everybody has it, but. Okay, all right, so. This is a document that may be familiar to you, that we've been projecting our cash flow to monitor our days cash on hand and. Projecting out as far as meeting the requirements of our owner's contribution on the project and all of that. So as you'll recall, back in early in the year, we had what we call a little dip there in February which was the time between when we made our IGT contribution, the intergovernmental transfer, and then the time that we received our payment back. We were helped out in the early part of the year because folks at California Health and Wellness did advance us $1 million on our rate range, and we got it into wherever it is, March. And they also advanced us money on the QIP. So that kept us whole. We were going along. We knew we were gonna have a dip again when we went into the fall, but they were moving up rate range into what the IGT would be in September, and then we get our supplemental payment 60 to 90 days thereafter. We do the same ask of an advance, and we'd be okay. We have no reason to believe California Health and Wellness would not work with us again. And then a couple things happened. The first of which was we put the project out to bid again. Well, even before that, when we did the original bid and received the original approval from the USDA, they pulled a little under 4 million out of our ask, so we were already short then. And then when we came around in the spring and rebid the project, the bid came in, we were now 9 million short. Fortunately, we were able to work with the USDA and they provided the additional financing, but it also came with a price, the price being that we were now going to have to fund capitalized interest to the tune of a little over $2 million. Fortunately, Western Alliance Bank, our lender on the interim financing, said we don't have to put it all up at once. Said you can give us 500,000 and then do a sinking fund contribution to get to the $2 million. Well, that was 500,000 that we didn't have in our previous cash flow. So that's reflected in the August column there. We made that 500,000 contribution and actually have made the first two payments on the interest fund, the $235,000 payments there. The next thing that happened was DHCS, Division of Healthcare Services, moved the rate range IGT from September to November. So that might not sound like much, but what happens is that means that now we have to absorb 2 more months, September and October, that of negative cash flow, which we do from our normal operations. So just call it 600,000. So that 600,000 goes on top of the 500,000. But at the same time, we were working with the District Hospital Leadership Forum, DHLF, and they were able to coordinate conversation with California Health and Wellness and Anthem. This will be their last year of being in our rate range. Next year will be our first year of partnership. And they said that we had room to IGT more, if you want to call it that, where we had more uncompensated costs, where they said that you can IGT up to your uncompensated cost, and then in turn get more supplemental payments. So we said, great, everyone ran the numbers, and Ethan, if you can just go ahead 2 pages. Okay, so here in this document, calendar year 22, that was our supplemental payment, 3.884. We had budgeted that was gonna be the number for 23. There's not a lot of flexibility there. There might have been some more that the last year with the 2 plans, the pool would have been a little bigger. So to get that 3.884, we IGT $1.1 million. Well, when Anthem and California Health and Wellness says, well, we'll increase you. California Health and Wellness went up to $1.4 million of IGT. Anthem went up to 600,000. So now we're at 2 million in IGT. sorry about this, I don't make this up, I'm just the storyteller here. So part of the program is that a certain portion of the IGT is subject to a 20% admin fee by DHCS. Normally with a small amount like the 1.1 million, we missed most of that, but almost all of the new IGT was subject to the 20%, so we had to kick in another 200,000. The final piece there is that we had an agreement with C. Clark and Associates, DHLF, to help facilitate this, and we would provide them 15% of our net benefit. We had taken this to you guys a few months back. This was approved, so for this year, we have to pay that. Going forward, if we keep the 6.29 million supplemental payments, we won't have to pay anything additional to SCA just this year. They give us more next year, then they're proposing the same deal, but that's another story or another conversation. So anyway, we works down that now our net benefit is projected to be 3,884,000 versus the prior year of 2,751. So a net benefit with those two add-ons of 1.1 million. There's no way we could say no. You know, we talked to you about this, that this not only is gonna be the benefit for this year, but almost certainly this will be the baseline. That 6.299 will be the baseline that partnership uses for the first year that they work with us. Partnerships come out and met with us multiple times, their leadership. They're very impressed with the story we're telling. They're obviously extremely impressed with what's going on behind us here. So we have no reason to believe that this won't be it for, this won't be our rate range picture for next year, minus the 211 to SCA there. So we just said we can't do it. It was gonna put a pinch on us. And so after all of that went down, I said, wow, we're not gonna dip, we're gonna dunk. So it's just, we're gonna get really low. And so I talked to Piper Sandler about it, and they just said, just talk to Western Alliance and get a line of credit, and no big deal. So that's where we're at. We had the conversations with Western Alliance, and what we planned, go back 2 pages to that quick one. So what's on the table is Western Alliance Bank is going to propose, or is going to put through their approval process, a line of credit of $2.5 million. And what we're planning to do is take that first draw as soon as we get the line of credit approved in the next couple weeks. And what we'll do is we'll pay all our vendors. We absolutely cannot use it for our IGT. We can absolutely use it to fund our operating expenses and payables, so that we don't have to touch the amount that we have right now in our reserve account for IGT. Then all's good with the world. And then Ethan, if you can go to the next page. And then in the 60 to 90 days, then in sometime in February, probably late February, we'll receive $6 million there.
And give back the line of credit.
And down at the bottom there, you can see that we pay back, whether it's this 1,750,000, or if we make additional draws, you know, regardless, we'll pay it back immediately.
So with that line of credit money, what will our daily cash on hand get to? Worst case scenario.
Yeah, Ethan, if you can just go to the previous page 1 real quick. So what we're projecting is in that first month of November,
And the amount, it's with it.
we'll bring in and we are right at 46 days there at the end of October, you know, today. All in, including the IGT reserve. And then we bring in the 1.75 million. It's probably gonna be a touch lower because we'll be paying some more expenses.
But I think that we're gonna be around 30 days through those 3 months.
That's even with a line of credit.
Well, that's with 1.75, we still have
Until we-
another 750,000 that we can draw on. So, yep.
And then it bounces us back up though in February back to almost
Because
84.
the other thing that happens before you go, sorry,
Next
Deacon,
page.
But we
is
have to stay after the
what they-
USDA.
what the state also did to us is they moved the H2AF program. So now we're going to IGT in December as opposed to the spring that we did last year. But the good news is that we also received a pretty healthy enhancement from that program, from around 700,000 of a supplemental payment to a little over $1 million. So both of those programs are gonna provide enhanced reimbursement to us. Now you go to the second page.
Is this a concern with the USDA? Their daily or their cash on hand getting so low?
Of course it is.
Yeah.
Yeah, so right now, we have no covenants, if you will, regarding cash on hand during the interim construction period.
Although it's fully funded at the end of it.
We have covenants with Western Alliance Bank.
Okay.
So their covenants are that, we will have 60 days cash on hand at the end of our fiscal year and 120 at the end of the calendar year.
Okay.
And with this
Right,
presentation, we hit those numbers.
okay.
We have to get the approval of the USDA to issue any debt. This Monterey emails there, we heard from legal says this is fine, we can do this. They said we do need the approval of the USDA. He said, our attorney said that the fact that Western Alliance is lending the money and has the interim financing loan, that should be a very positive thing for USDA, because it's just kind of like package deal. Plus, the key takeaway here is this isn't an indictment of our finances. This is, as you can see, a temporary
Yeah.
timing thing, just on the way that our resources come in, I guess is the best way to say it.
Right.
That's why there was some push in the legislature this past session about, trying to change the Medi-Cal payments to critical access hospitals from these, big outgoes and bigger incomes, to more of a flat, amount over the year.
Yeah, continuous, yeah.
So, it's an issue
Yeah.
it's an issue for a lot, on my calls, many hospitals are using. The line of credit mechanism to, pay their bills while they store money for their IGT, so.
Right. Very good point.
Yeah, so, after the 6 million, you see that the 1,053,000 is the new HQAF payment that we'll receive. We received some wonderful news, this past week that, our QIP audit was complete and, the team scored 100% on their audit, so we'll receive our full QIP payment, which, last go round was the 1.2 million that we show in May there. Again, we have to IGT in February for 321,000, so. Then at the end of all of those fun things, that's at the end of May, we're projecting 105 days cash on hand. One thing to note is that our operating income loss, it's a improvement on expense management and to the extent that we can. And AR account conversion. And those top numbers there, the operating income and loss could be smaller. So the encouraging thing is the outpatient utilization. Obviously, that's gonna, I almost actually contributed to the hospital when I hit Bailey Creek Bridge this morning.
The icy.
Oh my gosh, watch yourself there. It was frozen. So, but yeah, we'll see a dip as we always do in January, but that's where the inpatient side of things really comes into play. When I was in Nevada, the summers were gruesome for revenue. Cause, no one's sticking around in rural Nevada. They're going on vacation, they're doing things, kids aren't in school, aren't spreading diseases or viruses and stuff like that. And then when we get to the winter, that's when the flu kicks in and everything, and here we are truly the opposite because of the amount of population we have during the summer. So if we can, utilize a typical model for rural healthcare where we're seeing some, inpatients related to respiratory and whatever the other diagnosis is that you get when you get the flu bad and have some volume of inpatient in the winter to supplement the lower outpatient volume. So anyway,
So Steve, how encouraging is Western Alliance about the line of credit?
very encouraging. They, like I said, the legal's good with it. Western Alliance, the only thing they wanna know is it okay if we pledge the supplemental payments as collateral for the thing? And I checked with DHLF and they said that's absolutely fine, that is not a problem.
Yeah.
You just can't say you're using it for the IGT, but pledging it is fine. We'll see what the legal comes back with, and again, USDA should not have a problem with this. We're trying to schedule a meeting with them for this Monday. And, cause it looks like we're gonna have like a structure to the debt by the end of this week that we can send to USDA for them to, yeah, maybe not loan documents, but the structure to the debt that they can review. And as long as legal's good and the bank's good, then we're fine.
To me, this is all positive. I mean, I know it kind of seems, more line of credit, but I mean, if we weren't sending out these large sums of money in the first place, then we wouldn't need the line of credit to help cover our bills.
Right.
So I just want to I thank you, Steve, for presenting that. I just want to make sure that's very clear.
Yeah, and under full disclosure, it's probably an oversight on my part to not have this in place as we went into building a new facility or financing a new facility and doing an information system conversion, so.
No, you were kind of busy doing other things.
Yeah,
I think so.
It's okay, Steve.
a lot of other distractions.
Now.
I just had a big hat with lots of rabbits in it. So,
Well, Rich, do you have anything to add on this?
No, we discussed this at the treasurer's meeting and full support.
So we anticipate needing to have a special board meeting to address approving these documents required for the line of credit sometime within the next, probably couple weeks.
if not next week, absolutely the week after that, so if not the week of the fourth.
So
week
watch,
of the
watch
11th.
for communication from Deborah asking for times for availability, please.
My availability might be pretty tight next week.
Well, if we can have at least 3 people in here, we can have 2 people by phone. So we can work it out.
be here.
I'll be here.
And as soon as I know more about timing, I'll just share that with Deborah or you, Jerry, as well, and you guys can start trying to work on calendars, right? Okay,
Good, thank you. Any other questions for Steve on the cash flow?
Thank you.
Thank you, Steve.
And thank you for being so thorough with all of this.
Yeah, appreciate it.
I'm honestly, I'm not gonna spend time on the revenue cycle. If there's questions, I will answer them. I think the short story is that we're making progress, the numbers are getting better, but we still have a lot of AR sitting out there. That part's very troubling. Shelley, denials, are much improved. We found that a big part of the denials
was partnership because of, I know Brady kind of talked about it, but literally, we thought anybody could come here that had partnership. And they have to, it's almost as bad as the old way where they had to, I mean, at least there's the ability to do it. Under the old way, you had to get that direct thing, but, so we had,
Have to be assigned. Yeah, patients have to initiate that.
we also can get what's called a RAF, which is a 1 year, ability to come. They don't want you to make that a permanent thing where you just keep, raffing them. But, yeah, that was the bulk of it. Some of the other denials are relating to Cerner. The one under bundling is our rural health clinic, because they're supposed to roll up everything into one line item because we get paid per visit amount. It's supposed to just be a unit of one, the whole charges, the code. It was blowing it out, it was blowing it up, and it was putting multiple lines on there, and so they were doing the denials on that, so.
Figured out how to submit it.
We're working on it, it's a basic thing that. The problem with Cerner is, it breaks, it really does, like. Insurance rules or something, stop working, stop firing, or whatever it is, so it's a constant thing.
Yeah. Well, the 90 days, the AR 90 days, greater than 90 days, clearly I think we have to figure out what we're gonna do with that.
They're focusing on it because we truly believe that there's some denials, dead denials, that they're just not gonna be collectible. So one, we need to get off there, they need to find out what's still collectible and go after it hard. So there is some stuff in there that just needs to be written off, for whatever reason it is,
Okay.
timely filing, or whatever we want, so.
Yeah.
Okay.
What about self-pay? Greater
Yeah,
than 90
self-pay is rough.
Yeah.
We got so behind the 8 ball with not being able to get
Yeah.
the statements out. And
Dealing with that.
the public's been, for the most part, has been pretty good about honoring that, once the statements went out, we did see decent payments. What we haven't gone through yet is a bad debt turnover. And we still have a few more stages that we have to go through to send patients notices before we can get to that point.
Okay.
So that's a big disappointment for us. It really is. We wanted that to be, when you get a chance to have a clean AR.
Right.
So.
Well, that was a setback for sure.
Yes, it was.
Thank you, Steve. Any other questions for Steve? Thank you.
Thank you, Steve.
Yes.
Next up, we have item number 8, the Seneca Pacific Foundation report. Pacific Central report in. I don't know if anyone has any questions. Want the public answer?
Yes.
It looks like we had with recognition for 2 donations received, one from Plymouth Common Good and one from Douglas E. Chamber.
Great some recognition to Douglas Schamberger and Bloom's Common Good for their donation publicly, and then more of them. Got more.
Good.
Yeah, I liked her tagline that she had here, kind of how she had her laid out for the campaign. That was very informative.
So the donations that are coming in. And we still have our 500.
Right, so coming into Seneca Healthcare District 170.
Good.
The 501c3, I can tell you that I did have an email back and forth with Natalia from Kim and Kylie's office. She is following it, and they seem to be engaged. We don't have an answer yet though, but
So for right now, we're directing folks to donate directly
Correct.
to the district.
correct.
Yeah.
There are a couple of grants out there that are on hold for the 501c3 that are pretty substantial.
I understand from Chelsea, they're actually holding the fund.
They actually are.
So I thought that was amazing.
Yeah.
I think so too.
I was really
Which
surprised.
tells me they're committed to it. We just have to get that 501c3 and we're pushing as hard as we possibly can. And the confines of the government to get it done.
Any questions on this, board members? All right, let's move on. Lisa Donovan for our new First Texas Hospital Skilled Nursing Facility report.
Donna, you wanna go?
Sure. All righty, so. What we, with the schedule, I'm just gonna breeze through the report a little bit and do some highlighting of some topics here. So the decision was made by the team, as this indicated, is in regard to schedule, to postpone trying to do the trenching for both foundations and underground utilities for the building itself until spring of 2025. We did do an evaluation of that. The contractor was good in producing the couple scenarios that showed what we would gain for the risk of proceeding to do the trenching in the fall, as opposed to waiting to do it in the spring. And it was determined that it was really only a couple weeks of saved time. And so because of the risk of having open trenches versus just 2 weeks of saved time, it was determined to direct the contractor to not proceed with that work. Additional consideration was that we still don't have our core and shell permits for the building. And so it just made sense to not try and push it this fall, and instead just understand that we were going to start the building foundation and underground utilities starting in the spring. So
that all makes sense. The trenching that we are seeing, then that's just them bringing up to stuff, right?
Right.
Okay.
Exactly. It's all the site, and it's all within the, and it's all within the increment 4 approved plans. So it's the approved permit that we do have. We were battling with not just weather, but also trying to figure out getting the permit as soon as possible and making and giving the time for that. It was just too many risks to try and proceed beyond what the site trenching is that's going on right now.
No, that makes total sense. I want to make sure I knew kind of what was going on. 'Cause I'm like, I swear I see trenching, but
yeah, site trenching is what's going on right now.
Got it.
So we're evaluating what that does to the end date, if at all. We do have some weather days. I'm trying to further evaluate the schedule that the contractor has given us, and we'll report back to the board once we get through that evaluation.
Great, thank you.
So there,
Hold on one second, Donna. We've got some housekeeping items real quick.
then you just have 2 different ones up here. You put that in the right. And
All right, Donna, go ahead.
Okay. Tracking for budget, no changes to report there. We are for the pending ad services and change orders, we're working to develop a process with to incorporate the executive team review, the strategic planning review, the board review, USDA review, and what happens when within the process. So a flow chart to try and make that graphic has been developed, and we're working to get that in front of USDA to understand, as changes come down the pipe, does it go to the board first? Does it go to USDA first? Just trying to make sure that we're communicating with USDA to meet their needs around using the contingency that is there to be used as is needed, of course. That process will also evaluate with the executive team and the strategic planning team, making sure that we're evaluating the need of the change and being able to make that recommendation to the board and USDA after looking at clinical needs, looking at the big picture, and then being able to make that recommendation for each item. The design, we are working through some changes with the electrical engineer of record that has been brought on officially for increment 4, officially meaning, well, officially contractually for everything, officially for HCI for increment 4. But they are reviewing the big picture project in parallel to the permit going on. So they're working, and we do see some changes coming down the pipe and making some recommendations as was referenced within the pending ad services and change order requests. So things like we would anticipate a potential increase of the generator size as an example, to make sure, because they're looking at a more holistic making sure we're looking forward and planning as best we can. So all that's being vetted, nothing to jump on right now, but just know that there's some things coming down the pipe there. For permit, we are close with increment 1 and 2. We did hit some bumps in the road with the fire and life safety review, in that they are really short staffed with their fire and life safety officers in their in the office. And so their reviewers, they have asked their Southern California fire and life safety officers to step in to help with manpower, and they look at things differently than Northern California. And so we've had some conflict there that we're working through. We think we've come to a solution, and would anticipate resolution soon, honestly, sooner, I think sooner than what I'm showing on this report as the beginning of December. But that's a bit of a crystal ball at this point. It's my best guess that that's likely going to break free a little bit sooner. But again, because we're waiting till spring, it's not as critical. We just want to make sure that we're able to move forward with submittals and potential fabrication of items over the winter, even if we're not on site for those increments. For not anything hugely new on the medical equipment from the last report. I just updated some of the delivered items within the early procurement. So ultrasound's been delivered, an endo tower equipment / cart has been delivered. And so that's the kind of thing I'm updating in that portion of the report. As Sean reported, for construction, they're really doing a great job. They're working with us to move whatever they can move forward with increment 4 to the maximum, and looking to get as much done this winter within that increment 4. I'm sorry, within this fall before winter, within that increment 4. For the harvest plan, we determined in talking with the strategic planning team, it made sense to just keep that open. We did do some due diligence with talking with the harvest plan consultant, minimal cost to keep it open. And we have a tickler on calendars just to know as that deadline approaches for the permit to expire, just to do a check-in to be able to potentially do a 2-year extension. Or maybe do some harvesting before that closes, but it's like $1,000 a year maximum to keep it open, and then that way you have it available to you if you want to be able to clear some more trees. Say if you're ready to build the potential housing in the southwest corner, or whatever is decided.
So Donnie, the trees that you reference in this aren't referring to the ones that need to be removed for the hospital. They're ones that if we were to create the housing, we would need to remove for that, right?
Yeah, but even like as an example, the contractor determined that there were 6 trees that needed to be removed additional to what we did with our initial harvest. And so because we had this harvest plan still open, it was really not an issue to be able to just cut those trees. And so it's a really nice, a little insurance policy for you to be able to cut trees that, maybe affect the construction, maybe the 2 trees that are left in the grassy area to the east of the skilled nursing, maybe those eventually need to go. It just gives you a lot of flexibility to be able to take out a tree here or there if you need to.
Well, that makes sense. I'm just wondering why we're determining we need to take out 6 extra trees for the hospital.
Well, there was a trench that needed to go around in an area, and it was just too close to some trees, and they requested in order to trench it properly that we remove them 6. And we took a look at it from an aesthetic perspective, from a neighbor's perspective, and just because we had this open, said, yeah, let's go ahead and do that, so it didn't delay any of their groundwork.
So do we already done that then? Oh, okay. I thought we're gonna have to try and get the harvester
Take care of
back.
Yep, taking care of it. So and that's what's getting the insurance policy is that we are able to do this if we find something pops up like this. I'm gonna keep my 2 trees in the middle of the grassy.
Bird's gonna come back.
I take more grief for those 2 trees. Yes, you too.
We're gonna say.
So, but it's actually it comes in handy, so.
Yeah.
It's good insurance.
It's good.
So I would propose that I take this off of future tracking for the board because we're just gonna plan on keeping it open and nothing more to report really on that. For financing, the first payment was processed and paid. The second request is in to USDA. We've gotten some good feedback from USDA already for that one, and they asked for the unconditional lien releases that were required from the August payment, but that payment happened after we had submitted the September outlay request. So we're just anticipating that there's going to be that last little box to check for each pay app, because just the way it works, we don't have them to submit with the initial outlay request, but by the time they review them, they should be available. And so we'll just kind of push those through as USDA and Western Alliance are doing their review of the next pay app. Does that make sense?
Yeah.
Okay.
That all sounds good as long as we can keep it rolling.
Yeah. Yeah. And that's all I have. I'm open for questions.
Great, thank you, Donna. Any questions for Donna?
No.
Thank you.
Great work. Thanks for keeping on top of all of this.
All righty. Thank you, guys.
All right, so that brings us to item number 10, new hospital bill citizens oversight. I know we've had this on the agenda or partially on the agenda for a little bit here and there. So in talking with BBK, if we were to put together a citizens oversight committee, it would be a Brown Active committee and it wouldn't include any board members. And it sounded like not quite what we thought we meant when we were talking about it before. So Rich and I have had some discussion around this, and we also asked BBK if we are required to have a citizens oversight committee, and we are not. We have reference in our ballot measure to citizens oversight, which, I mean, we're presenting everything in this meeting. Dawn is bringing everything here. Steve is bringing all the information regarding the draws. We have our budget. People can see the construction. They can come to our meetings. They can watch our meetings. USDA is oversight on everything. The state has oversight over everything. So my suggestion, and I wanted to open up to see what the board thinks, is that that should be sufficient for our citizens to have oversight into our project rather than having a formal committee. That's my suggestion, but I want to hear what.
We are all citizens.
Yeah, we are. We are.
And we're supposed to represent.
Well, you're doing
And
the-
everything's public. Everything's public. Yeah, we're very transparent in all of our doings.
And as we know with the Brown Act, it adds a layer of complication because of the agendizing and the publication and
Yep.
hard to get citizens
To participate.
to participate and so on and so forth.
And then
So,
educate them on.
on how they have to behave.
Exactly, yeah.
That they
that
can't go out to lunch with each other,
too.
stuff like that. So, I think it's a good plan, and my question had been all along, what was it that we thought they would advise us on? Because they're not gonna be construction experts, they're not gonna be financing
Yeah.
experts.
I
And I kind of kept
think it was
thinking
more
in my
just-
mind
think it was more just making sure that
that they felt
their
good.
money is being spent appropriately with transparency, but because we are a public entity,
That's what I
all
was
of our
gonna say, it's all
finances
transparent.
are open to anyone at all
Right.
times.
Right,
It
exactly.
really open and transparent.
Yeah, I can't see the purpose of it, and if going forward, something developed where we felt like it was needed, we could always
Sure.
do that.
Yeah, and I think partly it came up because the school board, when they had their about measure B, whatever it was, to fund improvements to the school facilities, they had created a different citizens oversight. I don't think it was oversight though, they called it a
Advisory.
citizens advisory committee for each community to make sure that the money that was being spent in that community was being put to what the community wanted it for, and I feel like that's completely different from what we are doing.
Sure, because they were reviewing,
Multiple
should we
projects.
put in a new boiler or improve ventilation? And,
Exactly.
you know, various things like that, which is a totally
Completely
different.
different, because we're building one giant project, but one project rather than multiple projects. and
Right,
multiple
and as Sean said, it's all, I mean, any question anybody has can be easily answered, so.
So, Rich, do you have anything to add on that? Any comment?
No, thank you. You covered it very well. It just needs to be on our agenda every month as we do now. And I do, I do encourage that we try to get some more people to participate in our board meetings. So I don't know who's present from the community, but don't see anyone present from on Zoom. It's kind of discouraging.
Generally, they don't participate unless there's something they're unhappy about. So I'm taking that as a real good thing.
And you know, Rich, I will tell you that I have spoken with folks who do watch our recordings. They don't come to the meeting, but they
Okay.
do watch the meetings.
That's a good point. Good point. I like that.
I don't know how many do, but I do know that some have told me that, because they've asked me questions about this or that or whatever that we've talked about in our meeting, because they have watched it.
Good. Thank you.
All right, any other, Ken, did you have anything or?
No,
To add about that? No, Robert? No. Okay, so if everyone's all right with that, then we're gonna go ahead and just take that off of our agenda going forward unless it needs to get put back on for some reason.
Great.
Okay. All right, thank you. So that brings us to item number 11, naming the new hospital. We'll have some discussion around this, and I had a last minute when we were putting the agenda together, hiccup, because I all of a sudden went, wait a minute, we're talking about the Lake Almanor Community Hospital, and then I was worried about the Lake Almanor Community Foundation and whether that was confusing, and so I think Chelsea had something out about that. And I had previously spoken with one of the foundation board members, and she had originally had some concerns, but then Chelsea was okay with it. But by that point, I had already put it on the agenda as a liquid possible action. I guess I did do that. So I guess we can open it up for discussion if we want to go ahead and move forward with naming the new hospital.
Sure. I like it. I think it's much more specific, you know, versus Seneca, if people don't know what Seneca is when they're a tourist.
No,
here. They don't know that. They have no clue.
Because we're not even here.
And
Yeah.
this is going back to our discussion around incorporating the multiple communities that live around our lake. You know, it's not called Chester Hospital, it's not called Hampton Branch Hospital, Seneca, not really sure is, this really does incorporate the place we live.
Right.
And I think that our marketing perspective on this, we have the Lake Almanor Clinic, DBA. The Lake Almanor Community Hospital will be a DBA under Seneca Healthcare District, which will still be the parent. And the foundation is specific to Seneca Healthcare District, right? So I think that we were able to market this effectively and get that real clear communication out there about who goes with what. And we have a whole marketing plan for that strategy, so.
And Rich, I know you're always asking about, where does it say where exactly we're located? And Chelsea has assured me up, down, and sideways that all the communications is not in the logo, but it's gonna be at the top of all of the pieces of of communication that come out, say Chester.
Just in
California.
Chester, California, giving them the address.
Right, so that they know where it actually is located, because I know you've mentioned that before as being an issue.
I had the opportunity to talk to two people who are not only longtime residents, but they were both born and raised here and been here and worked and retired here and everything else. And I thought, well, this is a good chance to just see how married to Seneca names they are. And they said the same thing we've all said, is that most people don't have any clue where Seneca is. It's not a feeling of community. And when I explained that the healthcare district itself, the umbrella, was always gonna be Seneca. That we were just looking at, you know, the name of the clinic, the name of the hospital, any other things in the future that might be under that umbrella, they were all for it. And they kind of surprised me because I was expecting to have to really like defend this thing, and I didn't have to. So I think that most of the community, because we're not axing the Seneca name.
Correct. It's
You know,
still part of our
We're just,
DNA.
like you said, we're just naming a hospital facility the same way we've named the clinic facility.
Correct. And then logo. I'd like, if there's logos in here, I've got my favorite. I racked them 1, 2, 3. What we'd like to do, the action, I guess the action is going to Jeremy that's the adopt the name. And I would love the board to select the logo, or at least discuss the logo, so that we have the ability to actively participate in our marketing strategy, so that we can get this out there in front of everybody. We also have some time frame and restrictions around our signage. We need to start pulling them into our meetings now, because this will change the marquee. And we want to have some runway ahead of us in order to get ahead of this.
So let me interject and ask a process question. So
Sure.
I'm
I'll do
sure
the best.
that today we could agree to approve the name, but
Right.
do we have to have a resolution to do that formally?
I
I think we might
don't know.
want,
Grant's gonna be on here in a little bit. Maybe we,
well,
I think it would be good to
I
have
think we
one
may
just
want
for future reference.
all right.
yeah, so I think we can probably agree today, but I think we probably should have a formal resolution saying this is what the name is.
Can we do that during the special, that we talk about the line as
Yeah,
well?
if it's ready, sure.
Sure, we can do that. I'll have it scripted up by BK, to talk about
So I
qualifying
think
that in a
it's such a
resolution.
formal thing.
It'll have to have the address and everything, so yeah, we'll put that into a resolution. Deborah, will you please note that? Okay, thank you. And then the logo, you know, just so I've racked them and stacked them. I've looked at these things so many times.
The only challenge I have is those don't look like our mountains. Those look like mountains in the eastern or the southern part of the state where they go boom like this from the foothills up to the, yeah.
Every time I come in driving in, I look at the class and I
Yeah.
go, boom. They're like bang, there they are. This is,
I want to say this one is my least favorite,
Yeah.
because the other two, if we go back to the other
Thank you.
two, have the hint of a lake.
it looks
in
like
there.
water.
Yeah.
Yeah.
It's supposed to be.
The question is, and this is a split, that no matter who you ask, is this, which is a little bit off center, or a little bit, you know, or that, which to me, that's my number one. That's the cleanest one in my eye. But I have a weird, I'm so symmetrical, it drives my wife crazy. So really, it's kind of a vote on which one we want to go with.
Yeah, I'm with you.
I just like it all centered up with the lake underneath it, and I don't know, you're good. You're more arty, you're more artsy.
What does everyone?
I agree on the elimination of the one that's split. The other, the middle of these, the middle one. It would be-
Oh, you're looking at a different page than I am. I was looking at the.
No, it just made it easier when they're all on the.
So the one, the bottom one, or the,
But I
that
like the
one's,
bottom one, like you say, it's clean, it's clear.
that one's out, right? The split,
Right, well, for me it is.
yeah, right. He's like, I like that one.
I like the bigger tree on the first one, I'm just gonna say.
I
like
like the
that.
bigger tree, actually.
Yeah, I think that's what's bothering me about the one with the middle is that the tree
It's
needs
too
to
small.
go over this way and needs to be a little bigger.
Yeah.
Okay.
Yeah, but a very.
Should we, take another stab at it and bring it back from the special?
Mhm.
Sure.
Is there a particular reason why there's only one tree?
So.
Well, after the Dixie fire, that's all we have left.
Yeah, I was saying, we still have more than one tree on the peninsula.
We can take another stab at this. This is literally just first blush. We,
I think the tree adds scale.
Tree represents our whole communication.
well, how about we let, put it out there in front of the community and see what, I mean, once again, this is the first step. Yep, that'll get them used to the change. Yeah, exactly. Yeah, and that has been the case, or they'll send them to New York.
Yeah.
Because there's a Seneca in New York. So, this is not, we're not born to these.
Soon, or do we have this made up for our signage? Like, what is our?
I think in the next few weeks, signage is still under development, right? So, is Donna still on? Donna, what is our,
Yes,
our next signage discussion with Wiener?
I believe we have it scheduled for the 6th. We wanted to wait till after this meeting here, this board meeting, to be able to discuss that.
So you can always decide on what the signs are going to be, but not necessarily.
Yeah.
Okay. So when do you have to have dropped that in order to still make our time frame?
Oh,
That's
yeah, plenty of time, I think, as it relates to, we know the size. I think the biggest one is gonna be the marquee is gonna grow in size. So they're gonna really wanna work on that. Donna, I would say that we have probably time to design, correct?
Yes, we do.
Okay.
How much time are we talking? Because if we're gonna put it out to the community to see if they have some ideas, we can't say we're gonna pick one of yours, but we would like to see if you have some ideas, and we might pick one.
Here are the things we're thinking about.
To do that, yeah.
Probably.
Yeah.
This spring.
I mean, I think we have time. I mean, we can bring it up to the signage folks at our November 6th meeting and ask them for what they feel the deadline is, and we can bring that back to y'all.
Frankly, we can put these in front of them too and just say, hey, why don't you guys come up with some design too? Because that's what they do. So,
Yeah.
Lake Almanor and just looking at, you know, the dimensions and that sort of thing out of them.
And in the sign, you have to have,
As instead of
yeah,
the
so
mountain,
these are all great ideas.
And
I think she was just sticking with the Seneca, not too far away.
Seneca brother.
It doesn't mean we're not married to this, but it was a story. Because we didn't know how much people would push back on getting too far away from our.
Yeah.
Well, and basically, like you say, that our current logo is the tree in the mountains and.
Yeah.
And so it's not a huge change other than the verbiage.
No, so we can do that. I just wanted, you know, as long as we are, I can start openly discussing it. Yeah, I think the thing is, do we want to wait for resolution before I start having dialogue?
we could probably have a motion now to choose this name as the new hospital name, and then just bring the resolution back later, right? I mean,
Codify it in the
all right,
resolution.
can we do that?
Sure.
I just want to be able to have, I've been kind of holding back on any conversation with anybody.
Yeah.
And I would like to be able to be freed up a little bit to have the dialogue.
Absolutely, yeah, no, I get that.
That we name the new hospital, the Lake Almanor Community Hospital.
Without the,
Right.
yes,
Lake
okay.
Almanor Community Hospital.
Thank you.
I second that.
Okay.
Thank you. All in favor?
Aye.
Thank you, Cherry.
Aye.
Jen,
All right.
Rich,
Aye.
and I'll vote aye. There
Thank
you
you,
go.
thank you for it, and we'll start on the design.
Perfect. Very exciting to me.
Yeah.
All right, so next up we have our policies and procedures, and then we didn't realize until
the meeting, but we didn't put it on as possible action, taking action on these. So I think we're gonna have to not approve.
And that works for me. I had such a hard time opening this because I was on the road and I didn't get a chance to look at it, but I was thinking maybe I need to abstain, yeah.
Came in really to review it today and get in the system, but I did have a couple of questions. I don't know if you wanna, one of them was the HR attendance policy. And I just wanted, I see that we're changing kind of the procedure for what people are required to do when. I just wanted, I'm sure it's part of our MOU, but I just wanted to, okay, thank you. And then the other one was the remote work one. And I'm curious why we are changing this one so dramatically.
Me too. Wanna know.
Okay, so I'm sorry, I didn't read it. So what is the?
Here, as a remote work. This is one that we've-
Telecommunications, remote work.
That background, we've gone back and forth on this policy and had tightened it up to where I think the board was happy with it. So I'm wondering why it's coming back to us now to loosen it back up, I guess.
Yeah, sure.
And we don't have to answer that now, obviously, since we're not voting on them today.
We just reviewed this last week, but I don't remember what the changes actually were that made it so loose.
Well, there were strikeouts where we had in the policy that, it wasn't a substitute, a permanent substitute for a work arrangement or a permanent work arrangement. Those types of things were removed from it. And so I just was trying to get it, what, we had itches well before, our current staff with people being allowed to telecommute who really shouldn't have been telecommuting, which is why we had tightened it up like this. And so that's why I'm changing that. So we can have further conversation about it.
Well, we have a new HR director as well, and I think maybe
Yeah, that may be.
tabling this one and having them review it. I can tell you that some of, did you say that this is looser than it was before? Yeah, boy, it's just a hot button these days, isn't it? I can tell you that when we opened up remote work, we had discovered that unfortunately, some folks hadn't even logged on. We were able to check that through an audit, and so tightening it up is good, but we've got to have some parameters in there. We've got to have some
Well, this
bumpers.
loosens it. The changes that are proposed to it loosens it
Okay,
from what it was.
well, I think we give our new HR director a shot at
Looking at it.
looking this over. And determining, first of all, the request for remote work, what's viable for remote work.
Right,
And
especially in
then
our
auditing.
environment.
I think it gives the manager of that unit, of that person, a little more discretion in terms of what's appropriate for that patient, that person's scope of work. You don't think
Then you
so?
get into that favoritism.
Right,
Problem.
that was part of the
Yeah.
issue before.
It was.
Some people were given the preference and then.
And other people
Well,
wanted
that's
this.
kind of how I read that.
It's actually supposed to go up to the executive
Yep.
level before anyone is allowed.
So let's-
to remote.
correct.
It should be at the executive level, case by case basis.
Yeah, and it's gonna change again because we're getting, and that the reason it moved to the executive level is it required a VPN, which costs money to the organization. As we move to SharePoint and we have the ability to get into folders without a virtual private network, then, you know, it won't need our scrutiny so much. It does need scrutiny about viability of work and what can and cannot be done effectively from a remote location. And then, of course, I want some audits in there.
Yeah.
You know, we will be auditing. We're gonna have you sign this thing that says we have every right in the world to see how often you're there.
I want to pay some attention also to people who may be requesting permanent remote status, and those might be people who have a disability or something, and how that's gonna look, what that looks like.
Yeah, and I really think that's a one-to-one. That's a case-by-case basis.
So Rich, did you have anything you wanted to add about this one?
No, thank you.
Yes, I think if we can maybe take a look at that one again, and then we'll bring these back for actual. approval.
Judy, I had a couple of questions
Agendized properly.
about the policies, I think in red, that are supposed to be retired. There was two CPR ones. One I opened up, and the MCN policy manager, when I opened up, I don't know which one, of those, cardiopulmonary resuscitation or CPR, one said retire and one did not say retire. So is this a consolidation, or are these policies and procedures now included in a different policy, or?
Well, what we've been, trying to get away from, especially with nursing, procedural policies. We subscribe to Lippincott, which is a evidence-based procedural manual. So if there's a procedure, they're the ones who keep it up to date, but they've got references that are no more than 2 years old, evidence-based.
Right.
Right? And so we want to get away from procedural policies. If there's another reference that you can go to, if you're not sure how to do CPR with your current CPR card.
Right,
Okay,
right.
you're not having to look at
Right.
other policies. So you're gonna see more and more procedural policies getting retired, because now we have a policy that says, if it's in Lippincott, you're going to Lippincott.
Okay, refer to Lippincott,
Yeah.
okay.
That way,
Okay.
they're not trying to keep up with all of the.
So
evidence-based
duplicated, right.
references, et cetera. So
That makes
we're
sense.
gonna follow ACLS protocols and we're doing ACLS. We're gonna follow CPR, what we learned in CPR. If we have any questions afterward, we're gonna go to Lippincott. We're
Right,
not going to keep it in a
did we
policy.
follow? That makes
either.
total sense.
Okay.
Okay. Thank you.
Any other questions, comments on any other ones? We'll vote on these next time, since I didn't realize we didn't put it on for action, or put us on an issue.
So we just don't want to get too far behind, because we have grant funding tied to the number of policies that we're getting through.
If we bring it to our special, are we still okay?
That would be good.
Okay,
Bring them to the special.
yeah,
Yeah, great.
okay, we'll do that. I apologize, I didn't call, we missed that on there. All right.
So are they excuse me, so, those of us on the board, who have not approved yet in the policy manager, even though we approved here, is that an issue?
No. it's
For this
not.
grant
What
funding, okay.
Charlene decided, I think Charlene's on the phone, but what Charlene decided is that you're given the opportunity to review them prior to the board meeting. We talked about it at the board meeting where you can ask your questions, but ultimately, I believe, once it's signed off, approved by Jerry, it
Okay.
goes through the final approval within MCN.
Okay,
And as I mentioned to Jerry, we wish to be very careful not to go in there individually and mark approved, so others can see that you approved it, because that's a daisy chain meeting against the Brown Act.
oh, okay,
So you can go in and read it,
yeah,
but putting approved or disapproved or comments
Hmm.
is
That's a
the
board
daisy
act.
chain meeting.
Yeah, so I think once we vote on it here, then I will go in.
And approve.
To get my.
And mark it approved.
so okay, that's a problem, like I talked about.
No, it's okay, don't,
That's a really good.
I did that today.
that's why she mentioned it.
That's, yes, thank you.
Just we won't do it again.
So then the
Glad I-
other day.
Yeah, that worked, they're in for us to approve.
Yeah,
Yeah.
Okay.
Yeah,
great, so let's move on to
Deborah,
number 13.
The policies and procedures back in the special,
Special.
because it doesn't say action.
Yes.
Okay, so
Medical staff report, requesting a board approval for medical staff appointments approved at the medical staff meeting held on October 8th. It's like an initial appointment for Biblish John, MD, initial ER psychiatrist, reappointment for Thomas Greeley, MD, in the clinic. And do I have a motion to approve?
Move approval.
Thank you. Do I have a second?
second,
Thank you. All in favor, Rich?
Aye.
Ken? Sherry? Aye. Kelly?
Aye.
And I'll vote. And with that, we move into closed session. Anyone need a break or? is it okay?
just gonna be, it's gonna be.
I'm ready.
Close.
okay.
Yes, thank you.